Okay, welcome to today's webinar, the latest from the National Consortium of Telehealth Resource Centers. Today we are going to be talking about direct-to-consumer telehealth during the time of COVID-19. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. We have these webinars every third Thursday of the month, so check out our website for more information there. My name is Joe Schaffner. I'm the Assistant Director of Outreach for the South Central Telehealth Resource Center, and I'll be your moderator for today. Next slide. So located throughout the country, there are 12 regionally based telehealth resource centers, and there are 2 national telehealth resource centers, the Center for Connected Health Policy and the Telehealth Technology Assessment Center. And what these telehealth resource centers do is serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in remote and underserved areas. Each TRC serves a unique geographical region. And so if you are joining us today and aren't in contact with your TRC, holler at us after the event and we'll put you in contact. Next slide. Few tips before we get started. Your audio has been muted. Please use the Q&A function on the Zoom platform to ask questions. Questions will be answered at the end of the presentation. And please fill out our survey. We want to hear from you. Feedback is how we make these things great. So today's webinar is being recorded and you'll be able to check out this recording later on our website and on the TRC YouTube channel. Next slide. Okay, it is my great pleasure today to introduce today's guests and panelists. Stacy Petty is the Director of HealthNow at the University of Arkansas for Medical Sciences, also known as UAMS. Ms. Petty's clinical focus is on vulnerable patient populations, and her administrative focus is on making telemedicine accessible for all Arkansans. Dr. Joseph Sanford is the Director of the UAMS Institute for Digital Health and Innovation. He also serves as the Associate Vice Chancellor, Chief Clinical Informatics Officer, and Associate Professor at the UAMS College of Medicine's Department of Anesthesiology and Department of Biomedical Informatics. Dr. Sanford was the co-director with Dr. Kevin Sexton of the Institute's Healthcare Analytics Division. They have collaborated with the Arkansas Department of Health, FEMA, the UAMS COPH, the private industry, startup accelerators like the Venture Center to model disease spread, PPE, supply and distribution, pilot new technologies, and co-develop new intellectual property via grants and other opportunities. Drs. Sanford and Sexton and other research partners have submitted 6 patent applications to date as part of their work in the division. And Dr. Kevin Sexton is an associate professor in the Department of Surgery with secondary appointments in the Department of Biomedical Informatics, the Department of Health Policy and Management, and the Department of Pharmacy Practice, Division of Pharmaceutical Evaluation and Policy at UAMS. He also serves as the Associate Chief Medical Informatics Officer for the Innovation, Research, and Entrepreneurship at UAMS, and is the Associate Director of the UAMS Institute for Digital Health and Innovation. Dr. Sexton's clinical focus is on hernia surgery, and his administrative focus is on developing technologies for the rural healthcare market. Ladies and gentlemen, our guests and panelists.
Well, Joe, thank you for that wonderful introduction. You are too kind. If you want to move to the next slide, the first thing that we're going to talk about are some of our disclosures. Stacy has nothing to disclose. Joe and I have the disclosures that you see on the screen. Pertinent to this talk, we work with Deloitte on the National Emergency Telecritical Care Network, which is a direct-to-consumer model for critical care and COVID-19 services. And we work and have patents around telemedicine devices for auscultation, spirometry. We're not going to talk about any of those specifically today, but this are the companies that we work for or work with or have interest in. And now I'll kick it over to Joe to talk a little more about IDHI.
Thank you, Kevin. Next slide, please. So IDHI is part of the tripartite mission of UAMS. We are focused on clinical service, which is most of what we're going to talk about today in the direct-to-consumer healthcare model, particularly through our virtual urgent care clinic, HealthNow. We also focus on education, not just of the College of Medicine, but also with College of Nursing, College of Public Health, College of Health-related professions. as well as research and innovation, as was mentioned earlier in that very kind introduction. We are a fairly large organization, about 160 team members, and we are focused broadly across our service lines, ranging the gamut from primary care all the way to subspecialty oncology, neurosurgery, critical care, and the like. Today, why are we talking about direct-to-consumer healthcare? We see it as a growing an opportunity for partnering not just with other organizations in and about the urban centers, but also with rural America. Arkansas, for those that don't know, has a highly rural population with a wide socioeconomic demographic spread. So the kinds of work that we're talking about utilize any kind of digital technology, including telephony. We do not necessarily have a prior provider-patient relationship, and we are focused on notably the real-time interactive video components of patient screening. Our goal overall is always to optimize software devices and human interaction to improve healthcare of all patients. So with that, I'll pass it over to our director of the HealthNow program, Stacy Petty.
Hi, good afternoon, everybody. So yes, I want to tell you just a little bit about our program. If we can go to the next slide, please. So we were tasked with launching HealthNow in January 1st, 2020, and it was to be a virtual urgent care program that we offer 24/7. It was meant to be staffed by a team of nurse practitioners, and we offered this to all patients in Arkansas. They did not have to be patients of our hospital organization or not. It could be anyone within our state that needed care. And it was really an urgent care, primary care model that we set up. So if it was someone that had a sick kid on, Friday after the pediatrician office closed, as it always happens, or you wake up Saturday morning and you're not feeling well, you wake up in the middle of the night and you have fever and you just want to be seen. This was meant to fill that gap. So this is what we put into place. It offered affordable pricing for those that didn't have, for those that didn't have insurance. It was easy on their pocketbook. And then we also did accept insurance. So it was kind of the best of both worlds for all patient populations. We started with 8 nurse practitioners who took on-call basis, and we worked off of a internet platform where the patient would access our services. We would connect with them virtually and assess them and then perform the care that they needed. Next slide, please. So we have several technical components that we offer with our service. I think one of the most important things that we have integrated into our program is that we have 24/7 video support. That is not only for the provider's end, but also for the patient end. And we have this well marketed on the patient interactive side of our web page where they log in for a visit. So if they have any problems on their end, they can access technical support very early on, and that's available to them at any time. Also, we are able to access that technical support for the patient, and we are also able to add those technical support people into our call if needed. We run our program off the Visual platform, and we've found that to be a very good fit for us. And then we integrate our EMR via the enterprise system. We also have partnerships with lab providers across the state so that these patients, if lab work is needed, they can go to a local provider and obtain those labs. They accept our orders, and then those results get returned to us in a very timely manner. Next slide, please. So how our program works is that the patient accesses our program via a web page. They register their demographic information on our portal, and then they choose their visit type. based on what need their services for. We're then connected with the patient virtually. Our visit begins. We document in the EMR. If we need to, we can e-scribe a medication, order their lab, any other test such as x-ray, anything like that, make any kind of referrals. We can then send them any education that is needed, and then we end our visit. We can schedule any follow-up visits that they would need as well, and then all the billing happens on the back end. Next slide, please. So we were, just kind of learning, getting our feet wet and trying to figure everything out from January till, March 12th, I think it was. And then COVID hit and we were told, okay, guys, you've got 12 hours to turn your program into the state's first virtual COVID screening program. And we were just kind of like, we don't know what that means, but we'll figure it out and we'll get it done. And so that's exactly what we did. We turned it into the first service where patients could virtually connect with our providers and be screened to see if they were eligible for the COVID test. And this was at the very beginning where we had very few COVID tests. And this was 100% free service that we offered to all of the patients that were calling us. We continued this 24/7. And within that first month, really within the rest of March, we saw about 4,000 visits. Really, we spent more time educating patients on what we knew about COVID and what we didn't know about COVID. We spent a lot of time calming fears, just kind of walking people through what we knew about the disease, helping them just kind of understand and calm their fears and help them feel better about life and where we were going and how we were going to get through this together. And as that progressed over the next couple of months and we were able to get more tests and we were getting more answers, just how our world was changing and coping. And we would have moms call in stressed out, their kids were at home having school and one of them would get sick and, was the world crashing around them? And we just kind of talked them through things. And we would talk the elderly through, they hadn't seen anybody in months because they were quarantining and they just kind of needed somebody to talk to. And so we would stay on with them for 30, 45 minutes if we could and just talk to them. And then we try to call them back a couple days later and see how they were doing. So we actually kind of developed some friendships with some of these people and just kind of became their lifeline. And it was, that part of it was really great, but the initial part of it was really pretty exhausting emotionally, just physically, because we were just really doing calls all the time. Our whole system, though, really kicked in and provided a lot of support to our team. So that was really great to see. But yes, it was a really big turnaround. And I was very proud that we were able to fill the shoes and meet the needs of the community like we did. Because we heard from everybody that, thank you for just talking to me. I was just really scared. I just needed somebody to tell me it was going to be okay. So even though they called in with questions about COVID, I think mostly it was just they needed someone in the medical profession just to say, you're right to be worried, or we don't know the answer to that, and it's going to be okay. We're going to get through this together. So we really stepped up. Yes.
I was just going to say, I think one of the most interesting things that we went through in that first month, and particularly the first 3 weeks after pivoting kind of March to mid-April, was the logistics of managing the service. Could you spend a minute talking about, your perspective as director and managing your team and how you had to adapt and what problems were presented early? What solutions do you think served you well in the long run? What would you not do, or what would you do differently? Because I think I know we all certainly learned a lot working with each other in that moment.
Yeah, that's a great question. Thank you. So at that time, we were only had one staff member on at a time over 24 hours. So it could be a 7P to 7A, 7A to 7P, whatever. So we had very low volume at that time because we had just started our program. So when we changed and we were getting hundreds of calls an hour, even with me being a number 2 person as a backup, we couldn't keep up with that call volume. So even with all of our people on, 8, me being number 9, nurse practitioners on call literally every hour, we couldn't keep up with that. And so we extended, an all call for help, and we had a huge response. And we had so much volunteers that it was actually overwhelming for me. The help was really great, but it was very hard for me personally to constantly have to kind of bring all of these volunteers up to help them understand how to integrate with our technology and how to log on and all the little nuances to be able to help us. And there wasn't really very many people outside of our program that could really help me teach these people. So that was really hard specifically for me. But once I got a few people that could help me do that, then that really was a game changer. Because then it didn't require just myself to do that. So once I had 3 or 4 people that could actually onboard the volunteers that could help, and we started taking shifts and being able to relieve the HealthNow staff, then that really made the huge difference for us. That was a very good point. Thank you. So I would say if in my situation, if we had obviously known this was coming, I would say have someone outside of your program directly that has an idea of how to help you in case something were to happen, that just has a broad generalization of how you work and how you function or how your program works, your technology. Because if you get into a situation like that, or if something happens to you, maybe you get sick or something, then you need someone that can step in and help you fill that role. So that would be an important point.
And those are great points, Stacy. And I'm following the questions as they're coming up since we've spent some time talking about the tech stack. One is about the compatibility between the telehealth platform and EMR used, if it's total integration or something less. So for that question, the video visit platform is outside of the EMR, but all documentation is done within the EMR. I think as Stacy's highlighted, flexibility of platform is very much something we consider, and we wanted to be able to reach patients that were not already in our system for registration. And so let's advance to the next slide. So we kept the integration separate. We do have an integrated video visit platform, but for Stacy's team, we wanted this to be direct to consumer facing, and it had a different unique need and skill set for us. And that's why we went with separation of the two.
Yes, that's right. Also, we had tried to find something that had an integrated system, and it didn't really meet our needs. It wasn't fully what we wanted it to be. So we did choose to do the separated system, and it works very well. I do have to say, it does work very well, and it is very easy to document in the EMR, even though you're in a different system. It is very easy, and all the providers that use it have no issues with it. So it may seem like it's a clunky process, but it's actually not at all. So I would not say I would say don't let that be a deterrent for you.
For those that are on kind of one of the major EMRs and Epic, Cerner, the like, one of the challenges in patient acquisition, if they've never been in your system before, is how you handle novel registration and how someone can even request a visit. Even during the course of the pandemic, these systems have significantly improved. One of the things to remember is, we were looking at this from a 2018, 2019 development window into a 2020 January 1 launch. And so is the system that we would design today from today's feature set exactly the same? No. And there's a lot of work and complexity that goes on behind the scenes in terms of registration to make sure all the handshakes happen exactly as they want. But what we do have, as Stacy mentioned, and what we're focused on is something that works well for the team taking care of the patients. And so that really is, the tech has to serve Stacy and her team. You can't effectively bend a clinical team into your idealized tech stack. And so, Stacy, I think you touched on kind of the benefits of your approach with these references here. Is there anything else you wanted to add, or should we go to next slide?
Yeah, next slide's fine. So just a little bit more about our COVID response. In the initial phase, we did the virtual screenings, which were all face-to-face. And then during the peak phase, we were able to initiate an online screening that the patient completed themselves. And then if they triggered that they needed to meet with a provider, then they had the option of a virtual visit. And then we expanded our role in the COVID response to also include anyone that tested positive for COVID at our large facility. We were tasked with notifying those patients of their results and educating them on what that meant, and then educating them on their quarantine advisements. And then if they had any kind of physical ailments that they needed to be treated for, then we would then transition that over into a urgent care visit. We also started a Ask a COVID question inbox for not just patients, but anyone that could ask a COVID question just related to symptoms or testing. That has evolved now into including antibody therapy and vaccines. So we still continue to provide that service. And we also do return to work letters for COVID patients who have tested negative and positive. That is a service we offer for anyone, and that is allowed on our website. And then something else that we really have spent a lot of time on is screening and ordering the monoclonal antibody therapies. So that's been a really big thing that we've been able to provide as well. Next slide, please. So some other things that we've also branched out into other than COVID and the urgent care service that we provide, we also offer a teleprep HIV prophylaxis program. And we partner with the Arkansas Children's Hospital and the University of Arkansas system. And then we also partner with mental health services to provide a blueprint for their program. And then we just hope to kind of show that we can provide a backbone or a blueprint for other programs and services to be able to provide the same type of thing that we do. Just offer them the resources and to see how easy it is to do it, and that we are there to guide them and help them in any way that we can. Next slide, please. So I'm going to let Dr. Sexton talk about how we utilized IBM Watson during some of our really critical moments during COVID.
Thanks, Stacy. And this is the time in the presentation that I really wish I could see everyone and ask for a raise of hands of who felt overwhelmed at some point during the pandemic. I'll raise as many hands as I have.
Yeah, go ahead and type 1 in chat if you were overwhelmed.
But so we knew very early that we were going to be overwhelmed with the number of calls coming in. Learning from Stacy and from her teams, we knew we needed some sort of a technical solution that could help us scale to meet the growing needs of our patients. We already had an existing contract with IBM Watson, and so that's why we went with this tool. We had credits to use. What we did was set up a virtual assistant that was first on our website. We used IBM's tools to scrape the CDC website, our Department of Health website, and provide information on screening and do an automated screening assessment. Simultaneously to us developing this, Stacy and her teams were working with Vertriage, the company that was on the front end of the HealthNow tech stack, to do the same thing for patients as they came through. So that now, instead of having to call for screening questionnaires, folks could do this automatically. The bot would actually take registration information, pass it along to our clinic, and so patients would be pre-registered when they showed up for screening versus testing. What this allowed us to do, surprisingly, was get a ton of information on what kinds of questions and information our patients wanted access to. We learned very early that one of the largest areas or largest gaps of knowledge was obstetrical care during COVID-19. And so we specifically pulled data into Watson and added that for our patients. And if you'll go to the next slide, we had significant uptake, around 94% coverage, just meaning people get their questions answered within the system. In April of last year, we had 4,000 different encounters. Around 97% of these encounters are handled in English. The other 3% are handled in Spanish. We also have a Marshallese translation of this because that's a specific population that we help with. What this allowed us to do was to really focus Stacy and her team's time on patients that had a question that couldn't be simply answered. And so by adding the screening, we were able to reach many more patients than we normally would have. What we could also do is see the information that patients were asking for. And that's what the blue graph is in the middle. I'm sorry, blue or purple. I feel like I'm colorblind. It's purple. We could look at the different topics. The interesting piece is that some folks use this primarily as their source of information during the pandemic. We would have some users that would visit the chatbot every 2 to 3 days and ask the same question to see what information has changed. We knew when folks were becoming interested in vaccines. We knew really because of this information, what our next steps were going to be in how to deliver the best care. We also knew that to be successful, we had to expand access. The website is great, but that's not how most folks in certain demographics access information. It's still via telephony. So we migrated our virtual assistant to a telephone bot where you would call in, you would ask your question, it would guide you through the screening process and then get you over to our call center where you could be routed appropriately, including back to Stacy and her team on HealthNow if a visit was appropriate. All right, let's go to the next slide. Sorry, I saw something pop up in chat. Seeing if we need it. And then in this one, I'll pass it over to Joe to talk about our volumes and some recent experiences that we've had.
Get unmuted. All right, great. Thank you, Kevin. Yeah, so one of the interesting things about the telehealth opportunities, both required of and presented by the pandemic, was a necessary expansion when we shut down all clinic visits in the early days of the pandemic to get comfortable offering a wide variety of services very quickly. And this was aided by some regulatory relief and particularly the pairing of E&M coding to digital health visits by CMS. So on the graph here, you can see our Power BI dashboard. That's what we use for kind of data visualizations. And this just represents all telemedicine, digital health, however you want to classify it, type visits. And that includes everything that CMS pays for. So this is phone consults, this is bidirectional video visits, this is remote patient monitoring. It's the full gamut. We have done, as of when we pulled this data for the lecture prep, we had crossed 90,000 visits that were actually successfully completed, not just scheduled, over nearly 50,000 patients. We're on track for our 100,000th visit sometime on or about April 12th, if our forecasting holds true. We've seen patients in almost 3/4 of the zip codes in Arkansas, over 1,000 zip codes nationally, and we've done follow-up all across the country. One of the interesting things to call out in terms of the opportunities that having this extra piece of infrastructure in the health system gives you is flexibility for things that are not pandemic related. So you can see on the right-hand side of our chart here at the top, running from March all the way through to 2 or 3 weeks ago. You can see the dip down in the middle, just over January. That represents the 2 weeks around Christmas and New Year's, which is unsurprising. But the spike that reaches, height of the pandemic levels might not be intuitive as to why that was such a busy week for us, unless you live in the South and you remember that a couple of weeks ago we had what was dubbed, I think, snowpocalypse. And Arkansas, much of Arkansas, was pretty much completely shut down for most of the week. And Arkansas was able to get off actually fairly lightly compared to some of our colleagues in other states. UAMS was able to very rapidly reschedule a whole host of patients onto our telemedicine platforms and was able not to have 100% transition, because some patients would prefer to reschedule or some things are simply not appropriate for digital health, but managed to still serve the needs of those patients without over-long delays in rescheduling time, which is always nice in terms of timeliness of care and patient satisfaction. In terms of the day of week splits, you can see, at least for our telemedicine chassis on the health system, we are a weekday enterprise. HealthNow's numbers, when you call them out specifically, look a little bit differently because it's built for after hours care. It's built for weekend care, so it's going to be disproportionate in that respect. And you can see we're mostly doing business hours, but we have a fair spread throughout the middle of the night. Particularly, it's interesting that just before midnight, for whatever reason, that 2000 to 2200 hour window has an abnormal spike in it. I'm not 100% sure why that is. We don't really have enough sample to be confident that we understand why we see more patients in that representative sample. So we can go to the next slide. And this just illustrates that, as I said earlier, we see patients in every service line with the exception of pharmacy. And it runs, behavioral health does a lot of encounters, but we do have patients in our cancer center, musculoskeletal neurosciences, women's health. We have tried to enable this anywhere that we can in terms of making it an option for physicians and providers to have another tool to take care of patients. Our goal really is for telehealth and direct-to-consumer digital health to be just another tool that gets routinely used and is part of someone's training and experience. You can go to the next slide. And so I think, what does this mean for us in 2021 and beyond? Really, it's an expansion of service and coverage beyond primary care into subspecialty care in the DTC model. We are looking at particularly partnerships in the perioperative space because there are significant savings in the global for pre-op assessment and optimization, as well as post-op follow-up. You can do a number of interesting things in stroke care. We have a statewide stroke system, and trauma with a statewide trauma system, opportunities in cardiovascular care as well, just mapping the stroke, since stroke is a vascular disease. I think our opportunity is really only limited by our imagination, so long as we keep the patient front and center in our minds of exactly who we're serving, and in Arkansas that we're serving a rural community. So we do not want to be artificially committed to a solution that requires a video visit, requires a video link if we're in a state or region where broadband uptake is still relatively low. We would like to be able to meet the patient wherever they're at so that they can get the most effective healthcare. And so with that, I think we'll move over to questions. And Stacy, I've got one teed up for you because this was your project. Is there any more information on how we stood up and what the TelePrep HIV program does?
Sure. Yeah, I can talk a little bit about that. So our program, the HIV Teleprep program, we offer obviously telemedicine visits for those seeking the PrEP prevention prophylaxis, and we offer the assessment and lab for those visits. We are going to start offering the home visits, where we can ship the home visit to the patient and then schedule a time where we can have a visit with the patient. We can help them do the home test right there with them, and then we can finish the visit having those results in that moment with the patient, and go ahead and prescribe them the medication at that time, instead of having a wait in between a visit, them seeing a lab, you getting the results back, and then prescribing. So if anybody is interested in talking more about that, or finding out about our protocols or anything like that, I think our contact information is available, and I'm happy to talk with anybody. You can just email me, and I can give you a little bit more information about that. But we are partnering with some of our community leaders as well, and they are getting out in the community and really talking about this program. And so it is really going to be, it's been well received so far. We've actually gotten like 3 calls this week from a residential drug facility treatment that's found out about us, and their residents are very excited. Like I said, we've had 3 calls this week, so from one residential treatment center. So I think it's going to be really exciting, and we're really happy to be able to provide this service, and I'm happy to share any information with anybody.
Yeah, and I have to brag on Stacy and her teams, because they went about reaching a vulnerable rural population in ways that we wouldn't normally consider. I mean, taking out targeted Facebook ads to reach this group, and really partnered with our community organizations that are also referring these patients, to build a robust referral network so that we could have the best patient experience possible for these folks.
Okay,
I can touch. Oh, go ahead, Joe.
go ahead, Dr. Sanford.
Just because I was going to touch on one asked about the position of DTC HealthNow in terms of healthcare organization. So HealthNow through the Institute is part of the UAMS health system. So we operate under that TIN, if that answers your question. And then Kevin, there was one here about the future of VoiceBot. Where do you think that will go? Will it grow as patients adapt to it, or is it going to be a legacy product?
It's a good question, and something we're always concerned about when we create a new tool. I don't think this is going away, not for the initial reasons that I thought. So patients interact with the tool. They got very comfortable with it very quickly. And like we said, we were surprised by the number of repeat users coming back. Where this is growing has been organic. Our obstetrics and gynecology partners have been taking this technology and evaluating it as an intake for their clinic. They have really embraced telemedicine, as most primary care specialties have, and have started to use this as a way for patients to engage with them and schedule their own appointments and get information about delivery during the pandemic. And so we're really creating service line by service line sort of comprehensive packages around the VoiceBot to implement in their existing workflows. OB is picking new patients and patient education. Other places are picking scheduling patient appointments or follow-ups. Other places are picking education. We're really letting the service lines pick what they think works best for them and just helping facilitate implementation.
To the question, how was the work funded initially? So we were seeded by the organization to stand up a new clinical service based on our business plan. We also additionally, for COVID response, received philanthropic support as well as CARES Act money. The funding source ongoing is revenue generating with organizational support. On how and what buy-in is available from executive leadership in the initiation of your program, So executive buy-in is, of course, critical. It doesn't hurt that I have a role both in the health system as Associate Vice Chancellor and Chief Clinical Informatics Officer. So I get to kind of help bridge those gaps, as it were. But I can't underestimate the support and belief that both Chancellor Patterson, as a huge proponent of digital health, and Dr. Steffi Mehta, who is our CEO, they get it. They understand that this is a huge opportunity for the future of healthcare, and their constant advice and mentorship and support has been. It's difficult to underestimate the value of having them as allies and supporters of these programs. There was one other. Dr. Ross, can you elaborate on how patients are registered in your billing workflow? Yes, so very briefly, we use Visual as our front end so that we can do a street-facing registration and sign up without having to necessarily run through a complicated, we use Epic, so we're an Epic shop, so without having to run through a complicated reg process, even with quick reg. We have a one location web front entry because you still can't really create a MyChart account without having an existing registration in the system. We could get into the technical details of how you can sort of work around that, but it's not something you want to do as a matter of routine business at this point in time. So they create their account. We pass it through on our end to our 24/7 registration team once we've got it formatted in a way that makes sense for them. And then while the APRN is getting on the call with the patient, they are simultaneously being quick regged by the customer service team on the back end. They log into both simultaneously. We do all of the video conferencing on Visual or eLink, depending on how you want to look at the branding, because we've white labeled it. And then on the back end, they are documenting everything as a new patient in Epic. Billing, therefore, is handled, because we've done insurance collection and registration, is either a cash basis or insurance bill through our existing rev cycle processes, which was enormously valuable. We went through a lot of work to make that infrastructure work, but the net result of it was a sustainable business operation. Whereas other versions you'll see that do either cash on the barrelhead through a payment system like Square, and then you have to reconcile at the end of the month with operations. I cannot. I'm an infrastructuralist generally. I like building good, solid technical systems, but even among that is something worth taking the time and effort to invest in. Marketing strategy. That'll be a good one for Kevin.
All right, happy to jump in. So when it comes to marketing HealthNow, we started with an employee-specific marketing plan as a large organization, mostly because that lets us test. With anything, we are very much ship a product, test, and then scale, so that we can learn where our pain points are and create more scalable systems. So our rollout plan was first to our own organization, then to all of the UAMS health system, and then to targeted populations. Well, and I should say, we didn't get quite that far before COVID hit and we launched just statewide. So we tried to do a controlled rollout so that we had firm systems in place. And then we tried to meet our needs, or meet the needs of the state as quickly as we could. What we did learn is that a direct-to-consumer model has about the most flexibility of any system in an academic healthcare system. And so Stacy and her team really could rise to the challenge of whatever was necessary for the health system. And I'll pass it to her to let her talk a little bit about how they pivoted from COVID screening to now doing bamlanivimab or other monoclonal antibody infusion assessments.
So we also did a quick pivot to bring up the monoclonal antibody screening and ordering. About 12 hours seems to be our target time when we add something new. So, you know, I've gotten kind of used to that, but that's okay. So we now are able to take any internal and external referrals from anywhere across the state for anyone that would, and from patients also. We've set up an email system where people just send in the patient information. We then contact the patient, complete the screening with them, and then if they meet criteria and are already a UAMS patient, then that obviously makes it a lot easier. We just put the order in our EMR. If not, then we have to do a little more legwork, which is fine. And we do that and then get them in and get them scheduled and seen. So that has also been a very patient-centric, patient satisfaction, patient-pleasing service that we have offered. Another also very just hand-holding, question answered, just something that they've just been grateful for, even if they don't qualify for the service. Just thankful to be able to talk to somebody, see somebody, just somebody that listens to them. So that is one thing I would say about this whole direct to consumer thing, is that I can't tell you how many times patients have told me, this is exactly what I needed. I don't feel good enough to get out of my jammies and to brush my hair and brush my teeth. A lot of times, not inappropriately, but patients will call and you can tell that they're still in bed because they don't feel well enough, or their kids, are laying on the couch in their jammies, laying on their mama's lap. I mean, this is exactly what we want this to be, so that people don't have to get out when they don't feel well and possibly infect other people and take time off work and have spend gas money that they don't have, and all of those kind of human things that we all struggle with, especially in a rural state and a poor state. People say this was so much easier. I want to see all my doctors like this. Can I do that? And we just say we're trying. So patients really like it, especially because they feel like, well, it's just like I'm sitting in the room with you. I feel like we're talking, we're just right here. So patients really like this. I feel like if you know how to do it in the right way, especially if, in your assessments, you really can include your patient for most things. You can show them how to feel if their lymph nodes are enlarged. You can, show them how to be included in the assessment. Patients like that. And they really feel like, okay, well, I really am getting an assessment out of this. And you really do know what you're doing. And this really does feel like we have a connection and a partnership here. And they really like that. And so, I don't know. It's not just this cold video visit where there's no connection and you're just kind of talking at them. It's really not like that. If you know how to kind of do it right and enjoy the connection. It's just in a different way. So
Yeah, and I wholeheartedly agree, Stacy. And I think Stacy and her teams have taught me the importance of good lighting, adequate sound, and you feel like you're in the room with someone and how you're intentional. And we've even focused on like where you can put Epic on the computer screen or the video screen so that you make eye contact with the camera. So you seem to come through as more natural in conversation. And there's a lot of little nuances that I think we've learned and are just starting to codify.
Absolutely. And let's see, one more question. Are you finding resistance from commercial and government payers and or billing and coding errors from the provider side? So at the moment, no resistance. Payers are, under the pandemic rules, are very on board with this. We will see if that persists post-pandemic declaration. I am cautiously optimistic that it will, given conversations that I've had and some, I won't say reading of the tea leaves from what CMS is saying, but there are many things out there in the lobbying and advocacy world that everybody has agreed is just a good idea. Among them, pairing the E&M billing codes to the telehealth activity. Like, that's just obvious. That makes documenting this kind of activity so much more sensical. On the billing and coding errors from the provider side, We have not, that I'm aware of, primarily because of, again, good infrastructure is your friend here. We built the Epic encounters in such a way as to make these encounters easy to document, bill a code against, and close without gotchas, if you will. Stacy, your experience on it probably would be valuable to share because you do a lot more documentation in the system than Kevin or I do.
So we put a lot of time in the front end in trying to utilize express lanes, which is a feature of our EMR. Now, obviously, you can't express lane everything, as that's not appropriate. But for our basic things, that provides a good backbone for our basic documentation. And then obviously we document to that further when needed. But that it reminds you to hit all your necessary things and then go further from there. So that really helps us. We just gives us a template to start from. And so we utilize those, and then we just kind of broaden those when we need to. And then as far as our COVID stuff, we really build smart phrases and smart documents, and I do a lot of work with some of our IT people to really provide a lot of already built things for my team so that they just don't really have to search and think a lot, that it's already just built for them, and they just click on something and it's just all right there. So I would say that is definitely your friend as well, as much as you can do that, and and then teach your people. But if this is not all, make sure you're personalizing it to that patient and that visit. I find that, and my team finds that to be very helpful.
Okay, thank you so much, team. Let's see. We do have a couple of more questions up here, and we have time. From Suzanne, do you have any physical therapy providers utilizing HealthNow?
I can take that. That's a great question, Suzanne. We do not have PT as part of HealthNow right now, but I think it is going to be on our roadmap. Our physical therapists are using telemedicine, but they're using our integrated EMR system to do so at this point. However, Stacy and I have been working on a comprehensive abdominal wall center for hernia and other abdominal complaints, where physical therapy and rehabilitation are a big part before surgery. So we're looking at bringing physical therapy and partnering with our physical therapists in HealthNow. We just haven't done it yet.
Okay, thank you, Dr. Sexton. And we have one more here from Stephanie. Are there encounters created for patients, such as outpatient clinic visits?
Yes, so I can take that. The way that's structured, if you are in Epic or you speak kind of the EMR, HealthNow is another outpatient clinic department, and so we just create an outpatient visit for that.
Okay, thank y'all so much for your time and talents, sharing those with us today. I'm not seeing any more questions, so I'll just say thanks again to our panelists, and thank y'all for what you do and the healthcare that you do provide. So let's look at our next webinar for the NCTRC webinar series, which occurs every third Thursday of the month. Topic to be determined, but it will be hosted by the Northeast Telehealth Resource Center on April 15th, 2021. And it will be 11 a.m. Pacific time, 1 p.m. Central Standard Time, 2 p.m. Eastern Time. So check back on the website for more information there and registration information. And your opinion matters. We need your feedback to make these little events as helpful as possible. So if you could take the time to answer our little survey there, we'd really appreciate to hear from you, hear your opinions, and so we can improve our process as best as possible. So with that, I'll say thank you for joining us. Thank you for being here with us today. Everyone stay safe and have a great spring break.